banging on the table. The hearing will now come to order. As this hearing is fully virtual, we must address a few housekeeping matters. For today's meeting, the chair or staff designated by the chair may mute participants' microphones when they are not under recognition for the purposes of eliminating inadvertent background noise. Members are responsible for muting and unmuting themselves. If I notice that you have not unmuted yourself, I will ask you if you would like the staff to unmute you. If you indicate approval by nodding, staff will unmute your microphone. I remind all members and witnesses that the 5-minute clock still applies. If there is a technology issue, we will move to the next member until the issue is resolved, and you will retain the balance of your time. You will notice a clock on your screen that will show how much time is remaining. At 1 minute remaining, the clock will turn yellow. At 30 seconds remaining, I will gently tap the gavel to remind members that their time is almost expired. When your time has expired, the clock will turn red, and I will begin to recognize the next member. In terms of the speaking order, we will begin with the chair, ranking member, then members present at the time the hearing is called to order will be recognized in order of seniority, and finally, members not present at the time the hearing is called to order. Finally, House rules require me to remind you that we have set up an email address to which members can send anything they wish to submit in writing at any of our hearings or markups. That email address has been provided in advance to your staff. With that, let me acknowledge Ranking Member Cole and our colleagues for joining us here this morning. And I want to thank and extend a warm welcome to today's witnesses, Ms. Stewart, Dr. Sakala, Dr. Gordon, Ms. Asare, and we thank each of you for being here and look forward to your testimony. And I will introduce our witnesses further in a few moments. Today, we are here to examine the maternal health crisis in this country, which frankly, I think amounts to a national disgrace. When Stacey Ann Walker of Hartford, Connecticut was preparing to have her first child, she was 29, healthy, and excited to become a mom. But when she started experiencing shortness of breath, exhaustion, and swelling in her legs, her doctor brushed her concerns aside, saying these were normal aches and pains of pregnancy. Soon, Miss Walker's baby developed life-threatening complications that required an emergency C-section that left both mom and baby fighting for their lives. The baby weighed 2 pounds, 12 ounces at delivery, and Miss Walker developed heart valve problems and heart failure. Miss Walker, who was a Black woman, was lucky to come out of that ordeal alive. The CDC estimates that roughly 700 women die from pregnancy-related complications a year in the United States. Just very briefly, just a quick personal story. 16 years ago, my daughter Catherine went in with what was expected to be a normal delivery of our granddaughter. When she was ready to deliver the baby, they discovered an infection. Long and the short of it, the infection led to sepsis, and the infection spread to both my daughter and to my granddaughter, Rigby. Both were in the hospital in intensive care, and it wasn't clear whether either one of them would survive. With the grace of God, both of them survived. And Rigby today is 16 years old, and Catherine is thriving. I say that because oftentimes we don't think about childbirth as with the implications that are attendant to it and how dangerous it can be. And we just take it as a matter of routine. And I think today's session helps us to focus on what are the kinds of things that we need to do. And even before COVID-19, the maternal mortality rate in the United States was already more than double the rate of many other industrialized nations. Shamefully, our maternal mortality rate is higher than it is in Kazakhstan and in Kuwait. This is partly because our maternal health outcomes vary drastically by race. Black women, American Indian, and Alaska Native women are 2 to 3 times as likely to die from a pregnancy-related cause than white women in the United States. And the racial disparities persist regardless of income, education, and access to care. Worse, for every woman in the United States who dies from pregnancy-related complications, 71 women suffer from unexpected labor or delivery complications that have a significant impact on their health. However, it is important to note that this number does not include women who suffer from pregnancy-related mental health conditions. They are left out. My question, and I believe our question should be, why? The definition of severe maternal morbidity does not include mental health conditions, depression, anxiety, substance disorder, and maternal mental health conditions are the most common complications of pregnancy. Suicide and overdose are a leading cause of death for women within 1 year of giving birth. So the mental health related complications and deaths are in addition. Of course, the COVID-19 pandemic has only exacerbated these longstanding problems. Because of the pandemic, pregnant women, mothers, and their families are now less likely to pursue prenatal care, screenings, and other postpartum and perinatal care. Social determinants of health have a profound impact on maternal outcomes as well. These issues do not exist in isolation from each other. None of this happens in a vacuum. Substandard housing, food insecurity, maternal health care deserts, all of these challenges contribute to maternal health disparities and can have a devastating impact on the health of our nation's mothers, which is why I'm especially proud that we created a new pilot program last year to help state and local health departments to develop plans to address the social determinants of health in their communities. And I want to give a shout out to Congresswoman Bustos for her focus on these social determinants of health and where we need to try to go with these issues. As a proud founder of the bipartisan Congressional Baby Caucus, and I co-founded that with Congressman Denny Rayburg several years ago, and an inaugural member of the Congressional Black Maternal Health Caucus, I'm committed, as I think we all are, to ensuring the health and the safety of our mothers and our babies. I want to highlight 2 members of the subcommittee for their tireless work to improve maternal health and maternity care. Chairwoman Roybal Allard and Representative Herrera Butler are the founding co-chairs of the Congressional Caucus on Maternity Care, which is a bipartisan congressional caucus. This issue has been a priority for many other members of this committee as well. Chairwoman Lee, Representative Watson Coleman have been passionate advocates for reducing health disparities in all areas, including maternal health and maternal mortality. And while she is not a member of this subcommittee, and I'm excited to welcome Representative Lauren Underwood to the Appropriations Committee, she has been a leader in assembling a bill known as the Momnibus, which includes many new initiatives to address maternal health and maternal mortality. Over the past 2 years, this subcommittee has been instrumental on a bipartisan basis in increasing funding for grants and programs to improve maternal health. We increased funding for the Maternal and Child Block Grant, the Alliance for Innovation in Maternal Health, Maternal Safety Bundles, the Maternal Mortality Review Committees, and for the Healthy Start program. We also provided funding for midwife training scholarships and for state maternal health innovation grants to promote state-level coordination and innovation in maternal health care. Additionally, I am pleased that the American Rescue Plan extended Medicaid coverage for low-income mothers from 2 months to after birth, 2 months after birth to 12 months after birth, an expansion that is critical to improving access to care for vulnerable new mothers. But there is still so much more work to be done, as 12 states have yet to expand Medicaid. And beyond that, while it is a topic for the authorizing committees, we need to increase reimbursement rates, and those cannot wait. Today, we will hear from witnesses about some of the reasons why maternal health outcomes in the United States lag behind other industrialized countries and why disparities in maternal health outcomes persist. We will also hear about promising strategies to improve maternal health, how the programs funded in Labor HHS can support these strategies and improve maternal health outcomes in all communities. Our mothers are the lifeblood of our families, our nation, and our world. And those 1,000 days between the beginning of a woman's pregnancy to the second birthday of her child are already incredibly stressful, challenging, and life-changing. But now, for the first time in history, women are more likely to die during childbirth than their mothers were before them. This is unacceptable. As I said at the outset, it is a national disgrace. As a nation, we are supposed to value freedom, motherhood, and yes, apple pie. But we have to ask ourselves, if the United States is the bottom of the barrel when it comes to maternal mortality rates among industrialized countries we consider our peers, then are we really a nation that values the lives of mothers? 700 women are dying every day. Thousands more are suffering from either labor or delivery complications or pregnancy-related mental health conditions. Can we really say that our nation values mothers or the lives of those that they sustain? We owe it to our nation's mothers, to our families and communities, to ensure that not one more woman, not one more mother dies as a result of childbirth. We are fortunate that we are in a powerful position to help with this subcommittee, and I hope that this hearing will give us all a better understanding of what solutions there are and what we're able to do from an appropriations standpoint to address this inexcusable problem. Our witnesses today are all leaders in improving the health of women and their families. The panel includes witnesses who will offer nonprofit, academic, advocacy, provider, and state government perspectives on addressing the maternal health crisis. And with that, I yield to our ranking member, Congressman Cole.
Thank you very much, Madam Chair. Let me begin with a little housekeeping, if I may. I've, as you know, served as the ranking member on the Rules Committee, as well as on the Subcommittee on Appropriations. And in an hour, we start a hearing on war powers, which I know people are very interested in. So I will not be with you for the entire hearing. I regret that very much, but I just have to discharge my duties. But let me begin by wishing you again good morning. To you, Madam Chair, to members of the subcommittee, and to our testifying witnesses. I want to commend the Chair for holding yet another hearing on an important issue, one that touches us all. Today, we're here to learn about programs that seek to improve maternal and child health. Unfortunately, for far too many, the United States is not the shining example that it should be in this area. I hope with investments we continue to make to expand access to service and create change for expectant mothers in the health system, we can reverse course and lead the world in quality care for all mothers and children. I want to recognize as a leader on this issue and a proud member of this subcommittee, Ms. Herrera Butler. She sponsored and got signed into law the Preventing Maternal Deaths Act of 2018. In addition to this work, she launched the Congressional Caucus on Maternity Care with Congressman Paul Allard, another leader in this area. And I want to thank both of these offices for helping to prepare for this day. And I'd be remiss not to mention the decades of congressional leadership by the chair for efforts to improve the health and welfare of children. Chair DeLaura has spent much of her congressional career seeking to improve the lives of children and has been a longtime chair of the Congressional Baby Caucus. Our subcommittee membership has led Congress in legislative efforts and still continues this work with several proposals to advance newborn health screening and address the unique needs of moms in rural areas. The United States has one of the highest maternal mortality and infant mortality rates of all Western nations, a fact that's simply unacceptable. My own state of Oklahoma ranks as the fourth highest state in the entire country for both maternal mortality and infant mortality. It's an imperative that we do better. To address these problems, our subcommittee has made several significant investments to improve maternal health and address disparities in maternal mortality. We've increased resources to all 50 states and territories through the Maternal and Child Health Block Grant flexible funding that supports a range of health services for moms and babies. We've worked to establish maternal mortality review committees, multidisciplinary teams that comprehensively review deaths of women during or within a year of pregnancy. And I know in the coming year, we will do even more to support these programs. The leadership represented by this subcommittee in the area of today's hearing shows how important the topic is today and how fortunate this committee is to have such experts and champions making critical funding decisions on these programs for moms and their children. We all know the new virtual environment can pose an untold number of technical challenges. I want to acknowledge the work of the chair and her staff, particularly Tricia, and I know I'll butcher your name, Tricia, so I'm sorry, Castindi, for making these virtual as seamless as possible. I know a lot of hard work goes into that happen, and I certainly appreciate those efforts. And I want to thank all our witnesses for coming before us today, sharing their time and expertise. We are always grateful to have you. And thank you again, Madam Chair, for holding this hearing. It's a very important one as we go about our work for this session of Congress. I yield back the balance of my time. I think you're muted, Madam Chair.
Oh, hi. Hi, here I am. Okay, technologically challenged. But I want to thank the ranking member for his kind words, but also so much of the work and so many of the members of this committee have been really, leading the charge and been visionary as the direction that we ought to go in. And so much of the work has been on a bipartisan basis. And I think once again, we will note that even with all of our witnesses, this is the third a hearing that we've had where there has been such a consistency of message, if you will, on what the problem is and what we need to do about it. What are the solutions? And so grateful for that effort. And I want to apologize to my colleague, Congressman Fleischman. Both he and I chaired the baby caucus for a while as well. So that has been a bipartisan event as well. And with that, let me introduce our witnesses this morning. Stacy Stewart, President and CEO of the March of Dimes. Dr. Carol Sakala, Director of Maternal Health at the National Partnership for Women and Families. Dr. Wendy Gordon, Associate Professor and Chair of the Department of Midwifery at Bastyr University. And Lisa Asare, Assistant Commissioner of the Division of Family Health Services for New Jersey Department of Health. I'm going to turn it over to our colleague, Bonnie Watson-Coleman, to really introduce Ms. Asare.
I want to thank you very much, Madam Chair. And I want to thank you for holding this very important hearing. As the Assistant Commissioner in the Department of Health in New Jersey, she's worked for this department over 22 years, so she brings experience and wisdom to the position she holds today. She oversees 3 service units, which provide extensive public health service to New Jersey families, promoting and protecting health. And they include maternal and child health, special child health and early intervention services, and the state WIC program. And in this capacity, she has led the division's work in addressing the social determinants of health through multi-sector collaboration and public-private partnerships. And she's also worked very closely with the First Lady of the state of New Jersey, Tammy Murphy, who has been a leader, a collaborator, and a visionary in dealing with this particular issue. Ms. Asare is a graduate of the University of Toronto and has her master's degree in public health from Rutgers University's Biomedical Health Services. and she has many distinguished awards recognizing her wisdom and her contribution to these areas. And I welcome her, and I thank you for the honor you've given me to introduce her.
Thank you. Thank you. And with that, I want to remind the witnesses that the entirety of their written statement will be entered into the record. And we will now proceed with Ms. Stewart. Will you begin your testimony?
Thank you so much, and good morning, Chair DeLauro, Ranking Member Cole, and members of the subcommittee. Thank you for inviting me to testify today. My name is Stacey Stewart. I'm President and CEO of March of Dimes. We have many challenges before us as we are confronted with a dire maternal and infant health crisis. The health of women before, during, and between pregnancies. We need to do much more to improve outcomes for moms and babies, but the reality of this crisis that we're facing is truly startling. As you mentioned, Chair DeLauro, the U.S. remains among the most dangerous developed nation in the world in which to give birth, and it's more dire for women and babies of color. Preterm birth is a leading cause of infant mortality, which has slowly declined over the past few years, but today, still, in the U.S., 2 babies die every single hour, and 2 women die from pregnancy complications every single day. It's not just access to quality prenatal care that makes the difference in outcomes. Improving the health of a mom before she's pregnant, as she's trying to become pregnant, and even after pregnancy are essential. The 4th trimester, which is the 12 weeks after birth, is a vulnerable time when we must ensure moms and babies are receiving adequate care. The causes of this crisis are complex, but there is still much we do not know. The Preventing Maternal Deaths Act and the Preemie Reauthorization Act are enabling us to collect vital data and translate it into meaningful action to prevent future deaths. We're hopeful new efforts will spur further action, including a new HHS public-private partnership that we are undertaking to advance equity in maternal health through hospital-based quality improvement activities. This pilot, which is funded by United Healthcare, aims to improve outcomes for Black women in the South, and we plan to scale it to 100 hospitals over the next 5 years. With all of this, March of Dimes offers the following recommendations for FY22 funding. First, the Eunice Kennedy Shriver National Institute of Child Health and Human Development, NICHD, carries out groundbreaking research on preterm birth, maternal mortality, maternal substance use, and prenatal substance exposure. We request at least $1.7 billion for NICHD to sustain and enhance its existing research programs, including efforts on COVID-19. CDC's Surveillance for Emerging Threats to Mothers and Babies Network, SETNET, was designed during the Zika virus outbreak. It informs clinical guidance, educates providers in the community, and connects families to care. And due to chronic underfunding, CDC currently supports only 29 state, local, and territorial health departments. Therefore, we request funding for SETNET at $100 million to allow CDC to provide real-time clinical and survey data nationwide on the impact of COVID-19. Maternal Mortality Review Committees, MMRCs, funded by CDC in 25 states, work to identify, review, and characterize maternal deaths and prevention opportunities. We need more standardized data collection, which is so important and needed to examine all the factors contributing to maternal mortality, preventable deaths, and poor birth outcomes. We're requesting $30 million to maximize the reach and capabilities of MMRCs nationally. The Perinatal Quality Collaboratives, PQCs. PQCs are currently funded by CDC in 13 states, and they work to improve the quality of obstetric care in health facilities. However, many lack adequate resources, and we're requesting $30 million to fully scale these programs in all states. PRAMS, Pregnancy Risk Assessment Monitoring System, collects state-specific population-based data on maternal attitudes and experiences, covering about 83% of all U.S. births. We're requesting funding of $2 million to sustain this critical survey system. Newborn screening is another one of our most successful public health programs. Each year, 98% of the 4 million infants that are screened each year, that are born each year, are screened, allowing them to receive prompt treatment and care. saving and improving their lives. CDC's Newborn Screening Quality Assurance Program and HRSA's Heritable Disorders Program are also important. We urge you to provide $28 million and $28.883 million for these programs, respectively. Lastly, I'll just mention HRSA's Screening and Treatment for Maternal Depression and Related Behavior Disorders Program, an important program that we're encouraging more support of. $10 million we're urging to provide support to add 5 state grants. And we thank the subcommittee for funding $3 million for the maternal mental health program. I just want to say in conclusion, thank you for this hearing, and I look forward to adding more information about all of these programs that we're requesting support for. Thank you.
Sakala? Dr. Sakala, thank you, Ms. Stewart. Dr. Sakala?
Thank you. Chair DeLauro, Ranking Member Cole, and members of the subcommittee. I'm grateful to testify before so many stellar champions for women and families. I am Dr. Carol Sakala, Director for Maternal Health at the National Partnership for Women and Families. The National Partnership has been advancing economic and health justice for 50 years. I'm honored to be here today and encourage continued listening to those most impacted as you develop policy. Our nation fails to provide many birthing families with equitable, respectful, safe, effective, and affordable care. What can we do about the urgent, dire needs, especially of Black, Indigenous, and other people of color? Research shows that several models offer better care and outcomes now. I will briefly discuss 3 of those and one promising emerging model as outlined in the National Partnership's Improving Our Maternity Care Now report. These interrelated models contrast with much typical maternal care, for example, by providing personalized, respectful, effective care and achieving remarkable outcomes for such key indicators as preterm birth and breastfeeding. First, midwifery care emphasizes building a trusting relationship, promoting health, and tailoring care to needs and preferences. The second model is community birth settings. Demand is rapidly growing for birth in both birth centers and at home as appreciation for the distinctive care in those settings grows. The third model is doula support. Doulas are trusted non-clinical companions who help birthing people through comfort measures, emotional support, and information. And an extended model provides support from pregnancy through the postpartum period. Community-based forms of these models help meet needs of birthing families from historically marginalized groups, and a strong evidence base supports them. The final model is community-led perinatal health worker groups, which generally offer a range of community-tailored support services and may provide clinical care. They offer dignity and respect to clients who often experience discrimination in healthcare and everyday life. Although many of these multifunction groups offer proven midwifery, birth center, and doula services, their impact has rarely been evaluated. This model could play a major role in mitigating our maternal health crisis, and evaluation is a priority. We must also continue the longer-term work of transforming the maternity care system through payment reform, workforce development, and other levers, and we must continue to expand access to paid family and medical leave and other essential social supports. Here are some recommendations within the subcommittee's jurisdiction, and my written testimony has additional recommendations and details. Chronic underfunding hampers the potential of state perinatal quality collaboratives, which bring stakeholders together for quality improvement. We encourage the subcommittee's continued support of these groups. We also encourage the subcommittee to continue to advance maternal health through 2 new initiatives at the CMS Center for Medicare and Medicaid Innovation. By evaluating the community-tailored perinatal health worker models, and by carefully designing and encouraging uptake of a maternity care episode alternative payment model for accountable, higher quality care. Additional Agency for Healthcare Research and Quality funding could help fill glaring maternal health performance measure gaps. To foster needed improvements, we encourage a set-aside for person-reported measures of both the experience of receiving maternal newborn care and maternal health outcomes. Thank you to this subcommittee's maternal health champions, Chair DeLauro for leading on paid leave and paid sick days, Representatives Roybal Allard and Herrera Butler for leading the Maternity Care Caucus, and the majority of members for leading or co-sponsoring priority maternal health bills, including the Black Maternal Health Momnibus, Babies, Midwives for Moms, Mamas, Family, and Healthy Families Acts. Gratefully, the subcommittee's investments in federal programs target inequities, fund essential work, and are making a difference for moms and babies.
Thank you very, very much. Dr. Gordon, Dr. Wendy Gordon.
Good morning, Chair DeLauro, Ranking Member Cole, and members of the subcommittee, and thank you for the opportunity to testify today. My name is Dr. Wendy Gordon, and I am an associate professor and chair of the Department of Midwifery at Bastyr University, a small natural health college near Seattle, Washington. Thanks to the work of this subcommittee, my midwifery education program was one of the first recipients of the set-aside funding from the HRSA Scholarships for Disadvantaged Students grant that was earmarked for midwifery education programs in 2020. I and several of my students are extremely grateful to this subcommittee for that opportunity. I've been a midwife for 16 years, and I'm currently in active practice at a freestanding birth center in Seattle. I have a master's in public health, and I'm among the first to receive a doctorate in midwifery from an innovative program at Jefferson University. I've been asked to talk with you today about the importance of community providers in addressing the maternal health crisis. The US ranks far lower than most high-income countries and many middle-income countries with regard to maternal mortality, preterm birth, low birth weight, and infant mortality. Yet we spend more money on healthcare than any other country in the world. How does this make sense? There is a framework for understanding this, to think about it as a spectrum of care from too little, too late at one end, where people who need interventions can't access them, to too much too soon on the other end, where healthy people are getting routine interventions that they don't actually need. The risk of bad outcomes is increased at both ends of this spectrum. And there's a sweet spot somewhere in the middle where people only get interventions when they need them and in a timely manner. Midwifery care is designed for that sweet spot. In the US, there are 3 types of midwives that vary somewhat in their training. Some become nurses first, some are trained in hospitals, some are trained specifically to attend births at home or in freestanding birth centers. All are aligned with a low intervention model of care that research has found to produce far better outcomes for mothers, little to no increased risk for babies, and higher satisfaction with lower costs. There's a current shortage of obstetricians in the US to the tune of 6,000 to 8,000, and it is only projected to get worse over the coming decades. We cannot expect maternal health to improve with fewer and fewer providers. Meanwhile, midwives are severely underutilized in our maternity care system and attend only about 10% of births. In other high-resource countries with better maternal health outcomes, such as England, the Netherlands, Australia, and New Zealand, midwives are the main providers for all women, and OBs specialize in higher risk pregnancies. But in the system we currently have, it's hard to even become a midwife. The systems we have just don't support midwifery. Even though it is quicker and more cost-effective to educate midwives than physicians, there are no dedicated federal streams of funding for the education of midwives in the way that nurses and physicians are funded. I urge the subcommittee to advocate for continued and even expanded set-aside funding through the HRSA grant for scholarships for disadvantaged students. Midwife salaries are among the lowest for healthcare professionals. The cost of malpractice insurance is almost always covered by the hospital for those who are employed there. But for those of us working outside of institutions, we bear that cost ourselves. Many private healthcare insurers will not cover midwifery services in community settings, which means that the only people who can access this care are the ones who can afford to pay out of pocket for it. These gaps and barriers are pervasive, and they disproportionately impact communities of color. I urge Congress to pass the Black Maternal Health Omnibus Act so that these racial health disparities might finally be addressed. All women of reproductive age should have universal access to midwifery care and midwives who look like them. The policy environment and healthcare infrastructure should be fully supportive of midwifery care across all settings. Midwifery education should be funded, especially for people from underrepresented minorities. And programs should have the resources to expand so that anyone who wanted to become a midwife could do so without incurring crushing levels of student debt. To this end, I strongly encourage Congress to pass the Midwives for Moms Act to help expand the midwifery workforce. Thank you for the opportunity to testify this morning, and I'd be happy to address any questions that you might have.
Thank you so much. And now we'll hear from Lisa Asare. Lisa?
Yes, good morning. Thank you.
Morning.
Chair DeLauro, Ranking Member Cole, and distinguished members of the subcommittee. Thank you for inviting me to testify on this critically important issue. I would also like to thank especially Congresswoman Roybal Allard, Congresswoman Herrera Butler, and Congresswoman Bonnie Watson Coleman from the great state of New Jersey for their leadership on maternal health issues and requesting this hearing today. I proudly serve as the Assistant Commissioner for the Division of Family Health Services in the New Jersey Department of Health, and also as a member of the Board of Directors of the Association of Maternal and Child Health Programs, also known as AMCHIP. I'm responsible for overseeing a wide portfolio of maternal and child health efforts in New Jersey, many of which are funded at least in part by the very subcommittees that for the very programs that this subcommittee holds jurisdiction over. Programs such as Title V from HRSA, funding from CDC, funding from the Department of Education, and funding from the Department of Labor. But my greatest title and biggest responsibility is mother to 3 children, aged 24, 21, and 12. The United States has a maternal health crisis, as does New Jersey, with a ranking of 47th in the nation. This crisis does not impact all birthing people equally. It disproportionately impacts women who look like me, Black women. In New Jersey, a Black woman is 7 times more likely to die than a white woman due to pregnancy-related complications. This is one of the widest racial disparities in the nation, and evidence of a system wrought with many inequities and structural racism. I mentioned earlier that I am a mother. 2 of my children are girls, so this work is very personal. We can and must do better for my girls and all of our girls. Today, I'll share some promising initiatives we have underway in New Jersey under the leadership of Governor Phil Murphy and through the efforts of First Lady Tammy Murphy's Nurture New Jersey initiative. New Jersey made a renewed commitment in 2019 when First Lady Tammy Murphy launched this initiative, which is a statewide awareness campaign committed to reducing infant and maternal mortality by 50% over the next 5 years and eliminating racial disparities in birth outcomes, with the ultimate goal of making New Jersey the safest place in the country to give birth and raise a baby. Improving maternal health in the United States must include a focus on improving clinical care, but we also must reach beyond the hospital and healthcare settings to address the social determinants of health. We have considerable work to do to reach these goals. The examples that I share will show us how we address equity, engage community, and foster cross-sector collaboration. Fortunately for us, we've been able to build upon the support of some of our longer-standing programs, such as the Title V Maternal and Child Health Services Block Grant. Some of the signature efforts funded by the Block Grant include the implementation of the Maternal Mortality Review Committee, allowing us to move from data to action, and the Healthy Women, Healthy Families initiative, which is focused on providing social supports through centering pregnancy, doula programs, breastfeeding, and fatherhood support. We've been able to develop creative strategies, look to leverage additional dollars to maximize ways to address the maternal health crisis. For example, we partnered with the Department of Labor to establish a community health worker training institute using apprenticeship funding. We've also partnered with the U.S. Department of Education on a preschool development grant, which we're using to develop a doula workforce, recognizing that preschool readiness starts well before a child even enters the classroom. Investing in doula support for mothers during prenatal labor and postpartum periods is critical to laying the foundation for a healthy start. So what is my challenge and what is my ask of you? Improving maternal health and eliminating inequities is a complex problem that demands diverse solutions and funding streams. I ask that you, Congress, and federal agencies take a page from New Jersey's plan and prioritize racial equity, provide opportunities for community engagement, facilitate cross-agency collaboration, and ultimately rebuild a new maternal and child health ecosystem. Maternal health doesn't just start when a woman becomes pregnant. It includes all of the critical events that lead up to this period, making it necessary to engage across the life course and across multiple sectors. To sum up, we do have a crisis, but we do our best to maximize limited funding. However, additional flexibility coupled with increased federal investment will multiply our impact. As I close, I want to emphasize we all have a role to play in addressing the maternal health crisis. There's no one magic solution and no single player. There are multiple solutions that involve all sectors, all of your subcommittees working together for the United States to become the safest place in the world to be pregnant, give birth, and raise a baby. Thank you again to the distinguished subcommittee chair, ranking member, and members of the subcommittee for inviting me today. I look forward to answering your questions.
Thank you. I want to thank our witnesses, really, again, the consistency of information on the problems and the solutions and their admonition to all of us to move forward. What I'd like to do is, because I know the ranking member has to leave for the Rules Committee, is have the ranking member move forward with his questions first, and then we'll resume. Thank you.
Well, that's very generous, Madam Chair. And let me start, since I won't be here at the end, and just thank you again, seriously, for this hearing. I've had the privilege of being your ranking member for 2 sessions, now a third. And I think this has been the best group of hearings we've had. You've really put a flashlight on some problems that we need to be thinking about as a committee. To our witnesses, our challenge is always, we're an appropriations committee. And so we never have as much money as we think we need. And the way appropes work, I always like to tell people, is you have to move incrementally and cumulatively over time, set long-term goals, because we're a committee that gets some money in a good year, a little bit more than we had, but not enough to usually address a problem like this. And this is a problem of enormous scope and complexity, as all of our witnesses said. And frankly, it's a problem that ought to be an embarrassment to our country. It's just unacceptable to have these levels of infant and maternal mortality in an advanced society. So again, I applaud all of our members, as you pointed out, Madam Chair, that have worked on this. And I particularly appreciate our witnesses. I'm just going to go through the witnesses quickly and ask a question of all of you. And I'll start with Ms. Stewart, if I may, and then just sort of work through the lineup. But one of the most shocking parts of the testimony, of course, is the disparity geographically in terms of social class and certainly in terms of race that we see in our system. And again, that's not acceptable. So if you had to pick 2 or 3 things that you really wanted this subcommittee to focus on to address that problem, to get at the disparity outcome, what would those things do and be? And let me start, Ms. Stewart, if I may, with you.
Well, thank you, Ranking Member Cole, for that. And I just want to acknowledge, again, this tremendous opportunity and hearing. Let me just start with addressing a couple of things. One is, you mentioned that, we are facing an extraordinary maternal and infant health crisis in this country. Even in states like your own in Oklahoma, the preterm birth rates are enormously high. Every year, the March of Dimes issues a report card for every state and for the country, looking at the rates of preterm birth. Unfortunately, in many states across the South, some in the Midwest, we're seeing some of the worst rates of preterm birth of any places in the country. In Oklahoma, Unfortunately, the state's grade is an F compared to the overall US of a grade of C. That means that the preterm birth rate in Oklahoma is even higher than it is across the state, the country as a whole, where the preterm birth rate in the country is around 10.2%. In Oklahoma, it's around 11.5%. And among Black women, it's even higher. So the preterm birth rate for Black women is at 14.5%. It's 36% higher than the rest, than as compared to white women. So what can we do? Well, one of the things that we've been advocating for is that we have to make sure that women have access to high quality, affordable care. That means that every single woman should have access to being able to see her doctor affordably. We know that Medicaid covers between 40 and 50% of all births in this country. Women having access to the care, being covered by Medicaid if necessary, before, during, and after pregnancy. Making sure that women have coverage before pregnancy, and making sure that women have coverage and don't get dropped from Medicaid within a couple months after they deliver their babies is really important. So advocating for extending Medicaid 1 year at least postpartum. We got some of the way there with the American Rescue Plan, but we didn't get all the way there to make sure it's mandatory for all women. The second thing we have to really acknowledge, and why this coverage is so important, is because if we try to reverse these outcomes with moms and babies just during pregnancy, we won't succeed. We have to address the fact that there are underlying chronic conditions for women before pregnancy that have to be addressed.
I have very limited time. I only have 2 minutes left, so I want to get to the other witnesses as well. Please make it.
Thank you so much. Just want to end with this to say we have to look at the life course of women, making sure they are addressing chronic health conditions before pregnancy, during pregnancy, and afterwards. That would be a great start for all of us. Thank you so much.
Thank you very much. Dr. Sakala?
Yes, thank you. Very briefly, we have a data problem, and if we can't identify how people are doing relative to the average, we cannot improve it and address the disparities. So I would strongly encourage better, more consistent data disaggregation by race, ethnicity, and other demographic categories. And also, my second point, I would call for a better workforce development so that people are able to be cared for by people who look like them, who understand their life experiences, and who they can feel that they can build a trusting relationship, including community-based providers.
Thank you. We hear both those things a lot, data and workforce. Dr. Gordon?
Yes, thank you. I will advocate for the work that the Black Maternal Health Caucus has been doing with the Momnibus Act. There are 12 very well laid out bills that attack the problem from multiple different angles. And that would be my strongest encouragement for this work.
Excuse me, is it Ashwari? I hope I didn't mispronounce that.
Sorry, you're spot on. I think for me, I would really speak to developing the workforce, as some of my colleagues have mentioned, but I would also talk about cross-sector collaboration. I think it's everybody's issue. It's not just a health issue. And what we're doing in New Jersey is really doing a lot of cross-sector collaboration, maximizing other opportunities for funding, looking at workforce development through a training initiative, looking at developing a doula workforce through a preschool development grant, really looking to address food insecurity and many of the other areas. So I would say, I would agree with what my colleagues have said, but I would also add a cross-sector collaboration model.
Thank you very much, Madam Chair, for the consideration in terms of time. I'm very, very much appreciated.
Have not been through the Black Maternal Health Momnibus as a series of pieces of legislation, all of which are really very straightforward and would lead us in a different path if we wanted to change. So I would recommend members get hold of that. We can even get that out to folks, if you will. Just a quick second before I ask my question here is, I think geographically, I think we have to understand that the disparities are both rural and urban, as I understand it. And you've got rural areas where people have to drive for hours. And you've got hospitals where there are no services that are offered. And so we've got these, again, we've got food deserts in this country, but we have maternity care deserts, and they are both urban and they are rural. And there are no OB providers in these hospitals. And it's hospitals closing in both rural and urban areas where there is a concern. Let me just ask, and for anyone who would like to answer, there's very promising strategies that you have outlined. It's clear, though, that the country would need to see more systemic changes in maternal and perinatal health, and to make improvements across the country in the outcomes. How can the subcommittee support bringing these strategies to scale, if you will? And what else should the CDC be doing in this regard? So anyone who wants to answer, please. What are the areas we should bring to scale, and what could CDC be doing?
I'll answer the question about scale. We were extremely impressed by the results of the Strong Start Birth Center evaluation, 5 years from the Center for Medicare and Medicaid Innovation, which found that birth center care led by midwives was effective in reducing preterm birth, low birth weight, cesarean rates, other outcomes, and at lower cost. And I will observe that the Affordable Care Act authorizes the Secretary of Health and Human Services to expand evaluations that are found by the Innovation Center to improve care and save costs. So we would encourage you to work with the Office of the Secretary to determine ways to scale up that really powerful model.
Thank you. Well, let me move on. What about the perinatal care workforce? As I understand it, these collaboratives, there are only 13 states that have the perinatal collaboratives. What do we need to support a sufficient perinatal care workforce? And should we have one of these collaborative efforts in every state? I know you're going to say yes to that. I'm going to try to find out why we can't get them to every state. But if you could focus in on that for a moment. And that's for the entire panel. Again, anyone who wants to answer.
I can take that. This is Stacy Stewart. So yes, you mentioned the perinatal quality collaboratives, and these are really important because they're a national network of PQCs that really look at implementing targeted-based interventions, focusing on quality improvement, looking at the ways in which to reduce preterm birth. And they've done very successful programs to address early elective delivery, promotion of progesterone therapy. Right now, there are only a few states that are funded and supported by CDC at the state level. We really do need to make sure that we have expanded funding for the nationwide network of PQCs all around the country. That's why we're advocating for more an increase. These PQCs are really important because they get healthcare providers together to really design interventions that can really make a difference. We know that they've been successful. We've seen that. In fact, our current Deputy Chief Medical Officer came from the CDC and ran that program at CDC. We've seen it be an evidence-based program that needs to be expanded, and we would certainly advocate for that.
Okay, that's great. Thank you. Thank you. In the remaining time, what I want to try to do is to, Dr. Sakala, you talked about, well, we've addressed the issue, I think, of more data and the data disaggregation by race, ethnicity, and so that we can further pursue that. I want you to, if you a moment, Dr. Sakala, just to explain why paid leave and paid sick days are a maternal health issue.
Yes, thank you very much. Maternity care is critically important to healthy moms and babies, but many with paid jobs face an impossible choice between going to their provider visits or risking their jobs and income. And paid sick days are also needed to attend to and recover from numerous pregnancy conditions. Similarly, after birth, paid parental leave is critical for healthy family formation. New mothers who take paid leave have time to recover, including the 1/3 these days who are having a cesarean birth, and their children are more likely to be breastfed, receive medical checkups, and get critical immunizations. But only 21% of workers in the United States have access to paid leave through their employers. So for maternal and infant health, we need federal policy solutions like the Family Act for paid family and medical leave and the Healthy Families Act for paid sick days. And thank you, Chair DeLauro, for your leadership on these important bills.
Thank you. Thank you. My time has expired, so let me yield back and now yield to Congresswoman Roybal Allard. Let me yield to Congresswoman Harris, Congressman Harris, and then to you, just to keep in order. Congressman Harris.
Thank you very much, Madam Chair. Let me just ask a related question, and I will say I'm just a little surprised that in discussion about maternal mortality, we don't have a physician or an obstetrician gynecologist, to impart some information, because I'm going to ask about an issue that I know when I worked for over 20 years on a labor and delivery suite, the obstetricians always talked about was the cesarean delivery rate. And this is not discussed very often, but there are major differences worldwide, ranging from lower than 1% in some Central West African countries to over 50% in Latin and South America, Egypt, other places like that. So my question would be, I guess, for Mrs. Sari is what's your impression about what we can do to get our cesarean section rate closer to what the World Health Organization says it ought to be, which is about 10 to 15%. My understanding is now in the mid-30s, low to mid-30s. It varies over time, but I think pretty clearly a maternal morbidity can be related to our cesarean section rate. What can we do to deal with that, and what are the trends that you're seeing in both in your state and nationally?
Thank you for the question. We certainly have had very high cesarean rates in New Jersey. So this is something that we have been working on for quite some time. With the Perinatal Quality Collaborative, we've actually engaged in several AIM bundles that look at training and quality improvement, really working with birthing and maternity hospitals and providers on sort of best practices. One of the other things that we have done is with our Medicaid program, we've actually said we will no longer pay for early elective deliveries. And so we sort of have put in a financial disincentive to doing that as well. And then I would also go back to the discussion that we've talked about around workforce, really engaging midwives, really engaging doulas, because some of those labor supports can certainly help avoid C-sections as well. So I would say in New Jersey, our approach has been multi-pronged, really looking at training, quality improvement, looking at that financial disincentive, and then really looking at additional players in the workforce that can certainly help OBGYNs, as you've referenced.
Sure. Let me just follow up a little bit with that, because I know that the Cochrane meta-analysis of looking at the use of midwives indicates that in many places the cesarean section rate is not that much different. Now, that may be in countries where the cesarean section rate is lower than the United States. So first of all, do you feel that going to a midwife model, unless we change some of the other factors that might increase the cesarean section rate in the United States, for instance, obesity certainly is a factor in cesarean section rate. The liability issue is, I mean, again, to the physicians I talk to, that's one of their main concerns is the liability issue. What can we do to alleviate some of those things? And I also would ask you, in your Medicaid, when you lowered the payments for cesarean section, so brought them into line with what it would be for vaginal delivery, did you in fact see a change in cesarean section rate when you did that?
So we've just started. So invite me back in a year's time, and I certainly will have more to share with you on that. But I think you raise a valid point about the other determinants of what takes you to a C-section. Obesity, overall health, and so on and so forth. And that's why I think we're stressing so much this multi-sector approach. How do we make sure that people are eating better? How do we make sure that they're in their optimal state of health prior to even thinking about getting pregnant? Because all of those things are factors. So we don't zoom in only on the OBs and GYNs, but we really try to do a much more cross-sector approach, really looking at improving maternal health overall, and not just waiting for the period of pregnancy, childbirth, and postpartum to really address some of these issues. So things like Medicaid coverage for 365 days after delivery is certainly a step in the right direction.
Well, listen, I thank you very much, and I yield back, Madam Chair.
Thank you.
Congresswoman Roybal-Allard.
Okay. Thank you, Madam Chair, and thank you so much for holding this hearing on addressing maternal health crises, which is of great concern and of importance to me and my co-chair of the Maternity Care Caucus, Jamie Herrera Butler. Dr. Gordon, you shared in your testimony that Bastyr University recently received one of the 4 midwifery set-aside grants funded by the scholarships for disadvantaged students that this subcommittee supported. As a practicing midwife and director of a midwifery education program, please explain how midwifery education is different from medical and nursing education, and what type of further investment would be needed to support midwifery education programs across the country.
Yes, thank you for the question. Teaching midwifery clinical practice is very labor intensive, no pun intended. Student midwives are usually mentored by a practicing midwife who teaches and oversees their clinical skills in a one-to-one relationship. This kind of teaching is time consuming and usually results in decreased productivity on the part of the mentor. And there's no current mechanism to compensate that preceptor. Most of them do it as volunteers because they want to do their part to create more midwives. But this is just not a sustainable model. In some programs, the student is expected to pay their preceptor out of their own pocket. Most midwives don't have the expectation of greater earning potential when they graduate. Nurses generally command higher salaries than midwives. So it's harder to recoup the costs of their education, which can run between $40,000 and $100,000 for graduate programs. The current SDS set-aside is able to fund scholarships for only 4 midwifery programs, and I'm very grateful to have one of them. In the short run, it would be wonderful if that set-aside could be doubled so that a total of 8 programs could be supported with these scholarship grants. And in the long run, midwifery needs a dedicated stream of funding, such as what is proposed in the Midwives for Moms Act. And that would do 4 things. It would incentivize the recruitment and training of a more diverse midwifery workforce, first and foremost. It would support the students to complete their training. It would compensate preceptors with some sort of stipend, and it would allow current schools to expand or new schools to open so that we could increase the supply of midwives to address the maternity provider shortage.
Thank you. Dr. Sakala, last December, the Surgeon General issued a call to action to improve maternal health, and the Department of HHS rolled out the Healthy Women, Healthy Pregnancies, and Healthy Futures Action Plan. As someone who has been studying the U.S. maternity care system for decades, what do you think are the strengths and weaknesses of that call to action? And what can this committee do to ensure better coordination and accountability in the action plan?
Yes, thank you for this question. The HHS Maternal Health Action Plan and the companion Surgeon General's call to action were developed through an extensive process of stakeholder consultation, and they create a very comprehensive inventory of the work that is now underway across the agency. Moreover, the 5-year targets for reducing the maternal mortality and low-risk cesarean rates and controlling blood pressure in women of reproductive age are both important and achievable. However, conspicuously absent are mechanisms for coordination, communication, and accountability across the myriad initiatives. To maximize impact, I would recommend a whole of government approach. This could be accomplished, for example, through an interagency coordinating committee that meets regularly, issues annual reports, and works with this subcommittee to seize opportunities. High-level leadership within the Office of the Secretary would be optimal. And the National Partnership for Women and Families would be thrilled if there were mechanisms to add recommendations in our testimony to this action plan.
I yield back.
Thank you. Let me now recognize Congressman Fleischman. Unmute.
There we go. Madam
Okay.
Chair, thank you so much. It's good to see you and our
You
entire
too.
subcommittee today. Thank you to all the witnesses. Wonderful hearing. And Madam Chair, I also want to thank you for recognizing the baby caucus. That was really wonderful and something that was really uplifting for me, especially earlier in my congressional tenure. Want to ask some questions, and I will leave it open to all the witnesses, answer whomever may wish. 75% of women who experience maternal mental health symptoms go untreated. New mothers often feel isolated and alone, and social isolation caused by COVID-19 can exacerbate the feelings of loneliness. Peer support can offer an opportunity to connect with others sharing similar emotions. My question is, can you expand on some of the experiences and certifications held by peer support specialists, and what are the different types of peer support available? Thank you.
I think I'll take a stab at that. This is Lisa Asari from New Jersey. Thank you for that question. We have a maternal health crisis, and it is certainly being exacerbated with the COVID-19 pandemic. Folks are much more isolated than previously, and we've relied considerably on telehealth. But I would say one of the things that we are doing in New Jersey, having recognized the toll, we really call the mental health crisis the pandemic within a pandemic. We're doing quite a bit of work with our Community Health Worker Institute and really beginning to train community health workers to really also address mental health. They're not licensed practitioners, but we feel they can be they can provide peer support and certainly make the identification for women who need additional service, identification and referrals. And so that is one strategy that we're using. In addition to that, we do have legislation in New Jersey that requires that we screen all women for postpartum depression through their pregnancies. And so that is something that we already have longstanding. But certainly I would just say again, with the COVID-19 pandemic and the recognition that mental health is a pandemic within it, we are really looking to train doulas and community health workers as mental health peer counselors as well.
Thank you. Thank you for that answer. My next question, every woman experiences postpartum depression differently, but understanding the facts about PPD can help a person feel less isolated, particularly since PPD is often more than depression. My question is, how can we better screen for these symptoms before and during the 4th trimester? How can we work to change the stigma surrounding these symptoms? And how has COVID changed the way we provide support for the women experiencing PPD? And again, I'll open that up to whomever would like to answer that.
I'll just add a couple things about it, Congressman. I think a couple of things that, and I would have mentioned this too in response to your earlier question. One of the most successful programs that we've seen to provide support to women really before pregnancy, to your point, but also we're looking at a model that would provide support postpartum is around this idea of group prenatal care, but it can be extended into the postpartum era stage as well. We have seen, for example, on the prenatal side, where we've seen improved outcomes with respect to birth because of the group support nature of prenatal care that can be carried in the postpartum phase. We would like to see more and more of these kinds of programs be scaled because many, many women who experience pregnancy is already tough enough. Having the baby once they arrive is already hard. But that group support can be an effective model, that peer support that you mentioned. But the other thing I just want to call out too is the fact that we have done more, and thanks to a lot of your colleagues, to expand access to care with maternal mental health. The maternal mental health hotline that was started in FY21, funded at $3 million. We're advocating for more and increased funding for that. Can be another way to sort of help women before pregnancy and after pregnancy, to your point, be screened for mental health challenges and then be connected to the support they need. And certainly to your point, lastly, COVID-19 has actually exacerbated all of these issues around maternal mental health, and we have to shine a greater light on all of these challenges. So thanks for the question.
Thank you so much, Madam Chair. I yield back, and I thank you.
Thank you. And now let me recognize Congresswoman Barbara Lee.
Thank you very much, Madam Chair. Thank you so much for this hearing. And I want to thank all of our witnesses because you all have definitely laid out a roadmap in terms of solutions, and I really appreciate that. A couple of things I just want to ask you, but let me just put this in context of me personally. I was born a few years ago. My mother almost died in childbirth due to the fact that she was not allowed into the hospital because she was Black. And once they finally admitted her, long story, they did not provide medical care or care at all. And they had to finally do an emergency delivery and they had to use forceps to pull me out. And I had a scar above my eye for years up until very recently. Fast forward to today, we're still dealing with the same kind of circumstances in terms of the structural racism and racism in the healthcare system as it relates to Black mother mortality and infant mortality rates. And so you all have done a great job laying out the solutions, but I wanted to ask you a couple of questions. Why does the United States still lag in wealthy countries as it relates to maternal health outcomes? And then secondly, I guess Ms. Asare laid out the issues with regard to social determinants of healthcare and how all of these issues intersect in terms of Black maternal mortality and what have you. But beyond that, we still have barriers in the system and structures that need to be dismantled before we can move forward to, solve this problem, which is a deadly problem for Black mothers and babies. And so can you kind of describe what systems that we need to look at to begin to dismantle, and then what we can do in terms of the workforce, in terms of unconscious bias training, and is that included in the workforce training for midwifery and for nurses and physicians who are part of the delivery system for children?
Representative Lee, I can take the question on international comparisons. I was on the National Academy's study committee that developed last year's Birth Settings in America report, and we commissioned a study by an esteemed team of international researchers to understand differences that might explain the superior performance of maternity care systems in other high-income countries. And their analysis highlighted several things that are much more reliably available elsewhere. First of all, affordable and accessible healthcare without the kinds of barriers that many of our childbearing people experience here. Secondly, midwifery as the first line of care for the majority of women. Third, more standardized and centralized data collection to understand trends and rectify concerns. Moreover, there is more integrated systems based on respectful, trusting interprofessional relationships, both within care teams and across settings and providers. And lastly, they note that several countries also have national evidence-based guidelines developed through multi-stakeholder processes for all professionals versus our more siloed and uneven approach.
Thank you, Ms. Sorry.
Yeah, I would, you talked about bias training, but I think one of the things we've done in New Jersey is we've just listened to moms. Before we did anything, we actually went out into the communities and really talked to the same folks who are at risk to say what's going on. And what we heard certainly was about, sometimes lack of access to healthcare and things of that nature, but it was just stress, all the way across the board stress. I need a job. I don't like the schools my kids are in, transportation, childcare, all of those social determinants of health. And I don't always feel respected or treated well when I go to seek care. And so out of that, all we kept hearing was social support, social support, social support. That took us to the selection of things like group prenatal care, investing in doulas, really investing in other areas that would augment and ameliorate the quality of life for these women. So when we talk about this Community Health Worker Training Institute, it creates jobs for folks, jobs that make more than minimum wage, that we do in conjunction with community colleges, so folks have an opportunity to get an associate's degree and then get a bachelor's degree. We are sort of working with doulas, women from communities. They themselves have had poor birth outcomes, so they know what it feels like. They then are now being employed to be doulas, community doulas, and to serve their communities. We have a Medicaid reimbursement benefit, so now we have a sustainable funding source. So I say to folks all the time, health equity is not just about health. It's about money, it's about education, it's about housing, it's about all of those things. And so we try to be comprehensive in our responses to really meet women where they are, continue to allow them to inform us in our decisions and the selections that we made in terms of interventions.
Thank you, Madam Chair. Thank you.
Thank you.
Thank you. Thank you very much. Congressman Molinar.
Thank you, Madam Chair, and thanks for holding this hearing today. And I wanted to follow up on some of the comments you had made about, there's the maternity care deserts, mentioned the urban areas and rural areas. I represent a more rural district, and it's something that access to more specialized care in rural areas like the one I represent, 31% of Michigan counties have no obstetric services. And I wanted to ask the witnesses, and maybe start with Dr. Sakala, what can be done to increase the number of service providers who want to practice in rural communities? And are there any models that are out there that can bring these services back to rural communities? And then would open it up to any of the other panelists as well.
So thank you very much for this question. I think there are some residency training programs that are devoted to creating practitioners who feel confident and committed to working in rural areas. There are also some innovative ways that we can combine, for example, training general surgeons to be able to do cesarean birth and a couple of other crucial procedures. And then certified nurse midwives are able to have extra capacity in assisted vaginal birth, ultrasound, things like that. So we can be very creative. Also, there are a series of studies that show that birth centers in rural areas have the same high quality outcomes as in areas that are more closely located to backup facilities and higher level care. So all of those are some of the creative solutions that we might try.
Wonderful. Thank you. And
yes, I'd like to just add to that. Thank you for the question. The March of Dimes did a study on these maternity care deserts back in 2018, and we updated it in 2020. And what it shows is exactly what you said, that about Over 50% of the counties in the entire country are considered maternity care deserts, meaning they lack obstetric services, lack an OBGYN, a birthing center, no certified nurse midwife, virtually no obstetric services. It affects about, and then there are other counties that have very limited access to care. This affects about 7 million women of childbearing age, and it's a big issue. So here's some things that we would sort of urge everyone to think about with respect to how we address these gaps in care for so many women, where 4/5 of these maternity care deserts actually do occur in rural areas, to your point. First of all, we need to look at regionalizing care, where there's a sharing of resources across a larger regional area. I think one of the things that we've seen over the pandemic is this reliance on telemedicine and telehealth. We've got to expand access to digital access to care, especially for women in those rural areas. I think this idea of expanding access to midwifery care is also really important. Can we put more birth workers in areas where there may not be a formal hospital or birthing center to still provide that kind of care to women? And also incentivizing providers to be in these underserved areas. Do we provide enough incentives for people to work in areas where there may be a lack of care? So there are a lot of different strategies we can pursue in these maternity care deserts, and reaching those women where they are so that they don't go without the kind of care that they need, especially if they're in a high-risk situation. Thank you.
Great. And just to follow up with you on you mentioned telehealth. There is a digital divide in some areas. For instance, in my district, there are many areas where people aren't able to access the internet. How is that impacting maternal health services where there is a digital divide?
Well, we know one of the things that we've seen is that so many women actually went without prenatal care during the pandemic because they either were too concerned or too afraid to actually go out to visit their care provider. And if they didn't have access to those services by telehealth, they simply went without. And we did see a notable increase in the number of women, especially during the pandemic, who did not even receive prenatal care, which is, obviously a very dangerous situation, both for the mom as well as the baby. So one of the things that we've seen is that if women do have access, we've seen a greater comfort level with many women who would be willing to access these services if they had the kind of digital access that is required. So we've got to invest in those kinds of areas so that we can make that care more available to more women where they live.
Wonderful. Thank you. And thank you, Madam Chair. And I yield back.
Thank you. Thank you very much. Congressman Pocan.
Thank you very much, Madam Chair, and thanks for having this hearing, and thanks to all the guests. I think this is such a nonpartisan hearing. Almost every question area has had Democrats and Republicans asking in the areas, and I really appreciate that. I want to go to a couple of them that have been asked to ask a little deeper on, if I can. One is specifically on the mental health aspects. I know that Dr. Asari and Stewart both talked a little bit about this. Questions came from DeLauro and Fleischman. We have in Wisconsin, we have about 64,000 births last year, of which 20% of the moms were impacted by mental health conditions, but only 25% of those were able to get treatment. So we had nearly 10,000 moms not getting treatment. And there was the HRSA maternal mental health training program. Wisconsin applied for a grant, unfortunately didn't get it. Only 7 of the 30 states that applied got it. Can you talk, perhaps this one, Dr. Stewart or Dr. Asari, I think, who referred to this earlier, talk about that particular program and its increase in funding, and why that would help out in the mental health area?
I'd be happy to take that first. So HRSA screening and treatment for maternal depression and related behavior disorders treatment program provides grants to states to address maternal depression, and it really helps new mothers and their babies achieve the best possible start. With increased funding of about $5 million for this program, HRSA would be able to fund an additional 5 programs and provide technical assistance to non-grantee states. Right now, only 7 states have received funding, and we're able to create programs that really provide this kind of real-time psychiatric consultation, care coordination, training for frontline workers and providers, This is a critically needed resource. Again, through this pandemic, the rate of maternal depression and the rate of need with respect to treatment for maternal mental health conditions has increased 3 to 4 times that of what we saw before the pandemic. So these are really critical programs. We have to invest more in this. We tend to not pay attention enough to the mental health of moms, pregnant women, and new moms. We have to invest more in this, and especially during this pandemic, we've seen the rate of this kind of need increase dramatically, and that's why we're advocating for more attention paid to this issue as well as increased funding as well.
Thank you. I also appreciated the 4th trimester. I haven't heard that before, and I feel like I've learned a little on good terminology. A question on rural. Mr. Molinar asked where I was going, but I do want to take it a little farther. You know, in Wisconsin, I have 26 of my 72 counties don't have an OB/GYN, and we know nationally the rate of hospital obstetric services went down. Now we're at 55% in 2014 that didn't have that access. In Wisconsin, we have the University of Wisconsin-Madison has a great rural residency training track for OB/GYNs. It's the first training program in the country for rural women's health. Unfortunately, funding to train that program remains very limited. In the last budget, I appreciate the chair of the committee helping us get from 11 to 11.5 million for the HRSA rural residency training program. But could someone talk a little more, maybe Dr. Sakala, about this type of funding and why this is so important? Because again, my district is over half rural.
Thank you for that question. It's really important to try to find out who wants to practice in rural areas. And that includes people who have grown up in rural areas and want to stay in their communities. So these programs are really important for supporting them and dealing with the unique circumstances of rural healthcare practice. I would also identify an innovative program at the Frontier Nursing University where everything is remote except students come a couple times in the course of their training for nurse midwifery. And that enables people to reduce their costs and to stay in their communities, not even to leave for their education. So I think for some professional groups, we could consider expanding access to actual remote education.
Great, thank you. I yield back, Madam Chair.
Thank you. Congressman Klein.
Thank you, Madam Chair. I want to follow up on that very topic that Congressman Pocan raised. In answer to my colleague, Ranking Member Cole, several of you discussed the importance of developing the workforce as one of the main ways to help address this crisis. Not only do we have a shortage of medical professionals, but we also have a shortage of professors that train the next generation of medical professionals. Yesterday, I met with nursing deans, directors, and chairs from colleges across Virginia and in my district on this very issue. My home state has great options for nursing schools for prospective students, and often the waiting lists are long, but there is far more demand for spots than there is availability. This is coupled with the demand for medical professionals in the workforce and the demand for professors to leave the workforce to come and teach, and addressing that demand is a challenge. What are some of the best ways we can address this workforce shortage from both the education side and the career side? And Dr. Sakala, if you want to begin, and then anyone else who wants to chime in on that.
Thank you. So Dr. Gordon is actually a professor in a program, so I think she would have some excellent ideas about the pipeline for professors and academic leaders. So I will respectfully request that she provide an answer.
Perfect.
I'd be happy to. Thank you. Thank you for the question. It takes 3 years to educate a midwife. But right now there are fewer than 50 accredited midwifery education programs in this country. By comparison, there are almost 200 accredited medical schools. So we need to expand the programs that we have, and we need to create new schools. And both of those actions require funding. The Midwives for Moms Act would provide support for those accredited programs to create new schools, to expand existing ones, to support students directly, and also to increase the number of clinical preceptors. One of the things that I mentioned earlier in my testimony is that a lot of those teachers and preceptors are not actually compensated for that work. So being able to compensate people so that it's a feasible thing for them to do. And some of them, are earning from their practice, but doing this on a volunteer basis. And as I mentioned earlier, it does take more time to do that. So compensating people appropriately for the work that they do as clinical teachers and as academic teachers is really important for that to be feasible.
All right, thank you very much. I wasn't aware of the length of time to just 2 to 4 years by what I'm looking at here, depending on the plan and the and which format you're in, whether you're in a full-time or part-time. The training to become a doula, how long does that usually take?
Sure. Training to become a doula is usually much more condensed because it is not a clinical or medical type of role. It is a supportive role where people provide physical and emotional support during labor. So the role of the doula is largely putting tools in the toolbox to help support people to work through the intensity of labor. The time that it takes to train a doula may be a weekend workshop or a couple of weekends. Some of them now are online, and so they've been able to stretch it out and cover much more than just the hands-on work.
My sister's a doula, that's why I was just curious. Thank you for answering that question for me. So when considering the challenge for us to find incentives for nurses to leave the profession to become professors in the field, do we have that same challenge with regard to midwives? Are people not wanting to leave the field of midwifery to become instructors because of the pay cut that they would take in the same way that nurses would take a pay cut when they go to become professors?
I recognize the time has expired, so I will just say yes.
Thank you, Madam Chair. I wasn't even looking at the clock. I apologize. I was too interested in the subject. I appreciate the yield back.
Thank you. Thank you, Ms. Clark. Congresswoman Clark, there you are. Yeah.
Yes, thank you, Madam Chairwoman, for this excellent hearing and to all the witnesses for your work and being with us today. I want to go back to talking about what we know is our desert of maternity care in many rural and urban hospitals that have closed their obstetric units due to economic pressure and the high costs of providing maternity care. So can you speak to the role of birth centers and how they can help under-resourced communities? And I would look to Drs. Sakala and Gordon.
Okay, I can start off. As has been mentioned, over 1,000 counties have been designated as maternity care deserts. And this lack of access to maternity care poses tremendous risks to childbearing families, including traveling long distances, and especially when weather gets bad or in geographically dramatic conditions. And so several studies, fortunately, have found that birth centers located in remote areas have outcomes similar to those in more populated areas, even though the remote centers have less ready access to higher levels of care. So to me, this means that midwifery-led birth centers are a crucial piece of our rural access crisis.
Wonderful. Thank you. Dr. Gordon?
I echo everything that Dr. Sakala just mentioned, and it takes it's more cost effective to have birth centers in rural areas than to build a whole hospital. So the Babies Act is some legislation that would provide funding for Medicaid demonstration projects for freestanding birth centers in 6 states. And so given what we have learned from the Strong Start initiative and the studies that have come out of that, the Babies Act would be the next logical step in expansion of the freestanding birth center model. We also would need to make sure that there's licensing for birth centers that is available in all states. That currently is not the situation, and that would need to occur as well.
Can you give me an idea of the percentage of states that do have licensing requirements?
I do not have that number off the top of my head.
That's okay. We can find out. And thank you for the plug for the Babies Act. I appreciate that. I also, Ms. Stewart, I want to go back to the mental health impacts of this pandemic. And we know, as in everything affecting healthcare, there have been even more barriers for moms from communities of color and low-income communities in accessing mental health care. What are some of the targeted interventions that we need to effectively mitigate the inequities that persist in maternal mental health care access?
Well, thank you for the question. I think there are a couple things. One is that we simply have to acknowledge that mental health issues among pregnant women and new moms is significant. For too long, we've sort of stigmatized the issue and have underfunded access to care and made it much more challenging. That's why I think the funding that and the establishment of the Maternal Mental Health Hotline, which creates really services that are culturally appropriate, texting services, ways to provide 24-hour day care to women wherever they are, is really important. And expanding that access to care, that hotline is super important as well. But we also have to acknowledge that in the healthcare system, too many women of color don't feel adequately served, don't feel heard and listened to. We heard that earlier. And so this idea of expanding care, expanding access to care of doulas and midwives, research shows that that kind of care can actually produce better outcomes for mom and baby, reduces anxiety and stress. We know based on research the kind of impact anxiety and stress can have on women. We know that anxiety can be a leading cause of the kinds of chronic health conditions that actually exacerbate birthing outcomes that are poor for women of color, especially Black women. And so we have to do a better job of integrating our systems of care to make sure that as women are receiving adequate care for their physical needs, they're actually receiving the kind of care throughout pregnancy, before pregnancy, during pregnancy, and during childbirth, address their mental health needs as well. The hotline is really important. The other programs I've talked about earlier with respect to the funding that's being done by the Maternal and Child Health Bureau, those kinds of screening activities are also really important. And that's why we are advocating so strongly for expanded access and attention and care around maternal mental health.
Thank you so much. I see my time has expired and I yield back.
Thank you. Thank you. Congresswoman Frankel. Congresswoman Frankel? Congresswoman Watson Coleman.
I'm trying.
Oh, okay. Keep trying. That's
I got too many things going on.
there you go. Okay. We see you and hear you, Lois.
Okay, I got it. Thank you. I just really have one quick question, which is from all the panelists, is has I think the past 4 years, there's been a reduction of the Title X money because of a certain policy regarding it's the gag rule. I was just wondering if that affected this issue at all. Hello?
Thank you. I can jump in and say that pregnant people deserve access to the full spectrum of reproductive health care, and the ability to decide whether or not to continue a pregnancy and control over the timing and spacing of pregnancies is closely connected to maternal health. So we should be investing in healthcare that supports all of the different pregnancy outcomes and that gives people agency to choose the best option for their health and well-being.
I think just take that a step further. I know a lot of the Planned Parenthood facilities had to reduce their care. I'm just curious whether you saw any reduction in care over the last few years because of the gag rule.
I would say in New Jersey, this is Lisa, sorry, we had the benefit of having a restoration with state funding, recognizing that we had that situation, and we had a governor that gave us $7.5 million in state funding to mitigate some of the things that you're describing.
Oh, that's good. Thank you. Anybody else? If not, Madam Chair, I'm on another Zoom, so I'm going to yield back. But thank you for this. And I don't know if you did this, but I wanted to give a shout out to Brenda Lawrence, who really has been a leader on these issues and really, as the co-chair of the Women's Caucus, has really been pushing this as a priority to deal with these issues.
Keep zooming.
Thank you, Madam Chair.
Keep zooming. Congresswoman Watson Coleman.
Thank you very much, Madam Chairwoman, and to each of the witnesses, thank you so much for the information you shared. I agree with 1000%, and it has been very informative. I'm very proud of New Jersey, as you can see from Ms. Asara, just all the wonderful things that we're doing there. And I think that it serves as a model for other states to embrace. I want to talk a little bit about the disparities in mortality and morbidity in both mothers and babies as it relates to women who are of color and who share the same sort of socioeconomic educational background as white women, yet the disparity in healthcare outcomes is very different. And so I agree we need to have additional workforce, a greater access, but even for those who had the healthcare, something that I'm very concerned about. One of the first bills I introduced was the Moms Act, which was to give women a say at what insurance they needed as coverage when they found themselves pregnant, and would also extend Medicaid for a year for those. I understand the need for greater access to care. What I don't know is how we deal with bias. How do we deal with the bias that Black women and women, Latino women, et cetera, experience when they encounter the whole spectrum of healthcare as it relates to a woman's pregnancy? What is it that we're seeing that strategies that are used, educational tools that are used, accountabilities that are being used to help us to overcome that which I know is very, very tough to deal with and very, very tough to qualify and quantify? And I wanted to ask Ms. Asari, what in New Jersey are we doing to get at implicit biases? And then I'd like to also ask Dr. Sakala as well.
Thank you, Congresswoman. I really appreciate the question. I think the first thing we've done in New Jersey is we've called it out. In our Nurture NJ strategic plan, we've talked very specifically about structural racism. But thanks to HRSA and also state support, we have investments in implicit bias training. And I would go even further and call it anti-racism training. We are putting together a curriculum for implicit bias, anti-racism training that will take place in all 49 maternity hospitals, and not targeting any one group within the hospital, targeting everybody from the intake desk coordinator person, security, nursing staff, clinical staff, all of them, because we feel that it all contributes to that patient experience. I really appreciate your remarks about socioeconomic status doesn't change things. We know Serena Williams, as famous and as wealthy as she is, did not feel listened to. So we have considerable work to do in this space.
Let me ask you a question. Are there any changes that are taking place in the medical training that residents and doctors to be get and nurses get while being educated in college? Are there any changes into the continuing education requirements that doctors in particular have to have that address this issue? And if not, how do we address that? What can we do? What should we do as members of Congress?
Yeah, we do have legislation on the books that requires cultural competency training for medical students and residents. That was established back in the 90s, but we are currently working on legislation again around implicit bias training and talking to the medical schools, New Jersey Medical School, Robert Wood Johnson Medical School, certainly medical schools within the New Jersey system, about integrating that into the training. We need to go upstream. We have docs and folks who are practicing right now, but we're training folks as well. And it's really important to give them that requisite competency.
Thank you.
And if I could just add to that too, at the March Dimes, we offer implicit bias training for workers that are working with pregnant women and new moms. We've trained over 10,000 healthcare providers, but you're right, it does need to be further integrated into our training programs, our medical programs, nursing programs. It's not just the implicit bias, it's also the explicit bias and racism that really impacts the health outcomes of moms and babies in this country.
Thank you. It's an issue I'd really like to pursue, but my time is up and I appreciate the responses to my questions. I yield back.
Congresswoman Lawrence. Congresswoman Lawrence may have had to drop off. Let me just do this because we have a little bit of time, and I would just ask. I'll try to do the same order. If you have one additional question, and I would ask, the question be brief and the response brief. I'd love to get in any other efforts. We have a little bit of time here, so I will go last in that regard. So I think in order, Congressman Harris.
Thank you very much, Madam Chair. If some of the experts we have here would comment on the contribution of drug use to our maternal mortality and morbidity issues, and whether or not they think that the COVID pandemic is actually going to make some of these issues worse, as well as postpartum maternal depression. And any of the participants.
I'll start with that because I do think this issue of substance use disorder has really been a challenge. We know the opioid epidemic, for example, has really put a strain on many Americans. It's also put a strain on many women who are pregnant. One of the things that we've been concerned about is some of the punitive measures that we've seen taken against women who are maybe suffering from substance use disorders. We strongly encourage policymakers and others to not do anything that would discourage women from seeking the care that they need if they do have a substance use disorder, which is why we've been so supportive of measures to increase investments in making sure there's access to care, access to substance use support, including the Substance Abuse and Mental Health Services Administration's Pregnant and Postpartum Women's Program. That has been really important. Again, expanding Medicaid access, giving women the coverage that they need in order to seek that kind of care is also really important. We have seen, again, a slight decrease in opioid overdose deaths in 2018, but opioids are continuing to really ravage communities. And we're not only concerned with opioid use, but also other substances as well. We have to make sure that pregnant women feel the kind of support and receive the kind of support they need to make sure that they are protected and safe, to make sure that babies are safe. And whatever we can do to expand and make sure they're not further stigmatized because of substance use disorder is really important in this, in all of our efforts to protect moms and babies.
If I could just ask one follow-up to that, my local law enforcement tells me that methamphetamine use is going up. If I recall right, that is associated with some preterm deliveries. Are we seeing that an increasing problem nationwide among pregnant women?
I would just follow up to that to say that we know that the kinds of risky behaviors around the use of substances, smoking, for example, all of these kinds of risky behaviors can put greater risk for a mother to deliver early and deliver prematurely. You know, we've seen that data. We've seen that. That's why the March Times has been such a strong advocate for making sure that women receive the kind of support to reduce that kind of risky behavior so that they don't put themselves at risk. And I don't know that I have the data right in front of me, but it certainly wouldn't surprise me that with increased use of substances, that we would see some poorer birth outcomes as well.
Thank you very much. I yield back, Madam Chair.
Thank you. Thank you. We will do three-minute rounds here. Congresswoman Roybal Allard.
Okay, I actually don't have a question. I just want to point out a couple of things that were highlighted during the testimony. And one is from the American Congress of Obstetricians and Gynecologists report. It says that no significant increase in the number of medical school graduates entering obstetrics and gynecology residency over the last 3 decades, and projects a shortage of 6,000 to 8,000 obstetrician gynecologists by 2020 and up to 22,000 by 2050. I think that also highlights the increased need for CNMs and CMs, which would significantly enhance the ability to provide adequate women's health care in the United States. And I do want to put a plug in for the Midwives for Moms Act, which would increase the number of midwives educated in the U.S., and it will support the education of more culturally diverse maternity care workforce. Also, with regards to the point that was made by one of the panelists, was the need for better coordination and accountability in the action plan. And again, I just want to point out that the Moms and Babes Act that I'll be introducing provides or creates an HHS coordinating committee on optimal maternal outcomes that would help create that coordination and accountability that is missing at this point. So I yield back. Thank you for that opportunity.
Thank you. I understand some members have dropped off, so what we're looking at is Congresswoman Clark.
Thank you so much, Madam Chairwoman. I want to go back to the answer to Dr. Harris's question. Can we talk a little bit about, as we are seeing a rise in substance use disorders and the real impact it has, can you tell me a little bit more about how punitive policies hurt maternal health outcomes particularly for women who don't have access to quality healthcare treatment? And have you seen these policies result in a reduction of neonatal abstinence syndrome births and substance use treatment admissions? I believe Ms. Stewart.
I'm happy to start with that, and others can chime in. So one of the things that we have to all be concerned about is the impact of opioids on not only on the moms, but the babies as well. And we certainly have seen a significant increase in the rate of neonatal abstinence syndrome. The number of infants that were diagnosed with NAS grew nearly sevenfold between the years 2000 to 2014. Doctors consider NAS to be expected and treatable, but there are some very long-term effects to infants who actually suffer from NAS. When women are not able to access the care they need because of a fear of some sort of punitive outcome, that the rate of babies who then suffer from NAS can increase. And we know that that can provide, again, a long-term impact on those babies. And the impact can be quite severe. We know it's why the March Dimes has been such a strong advocate for making sure that these kind of punitive measures do not get implemented. We know that there has been a tendency to try to criminalize the kind of behavior that really needs to be treated as a legitimate mental health issue, and women need to receive the kind of care and support that they really must have in order to make sure that their babies are protected. We're concerned that even through the pandemic, the rate of increase and the rate of substance use has not declined. In fact, has just been exacerbated because of the pandemic. So we need to pay more attention to making sure that we don't further criminalize and increase any kind of punitive measures around women. Again, expanding the support that women need to have access to, especially if they're addressing a substance use disorder.
Thank you very much. I yield back.
Thank you. Thank you. I want to recognize Congresswoman Lawrence. I recognize Congresswoman Lawrence for 5 minutes, since she hasn't had any opportunity to ask any questions in the first round. Congresswoman Lawrence.
Thank you so much. Sorry I had to jump off, but thank you for allowing me. I have a bill for joining with the Senate, Cori Bush Booker, and the panel has just been excellent in talking about the power of doulas. And it's called the Doula Act. And what it does, it makes it an option for our women, veteran women, to be able to have access to doulas. But the thing I wanted to talk about is the mental health for mothers. We understand, and I'm looking at mental health on so many different levels. We have built into the care of a poor postpartum health care of women that they go back in 6 weeks to check on their physical health. We should include mental health as that check-in when we say, come back, mother, to make sure that everything is healing and you are physically recovering from your pregnancy. Why don't we include, at minimum, the suggestion of a check-in on your mental health? Because a lot of times women don't talk about it because some are embarrassed, as you know. Why am I depressed? I had the most amazing experience in life and everyone is so happy and I'm depressed. What's wrong with me? And they won't talk about it. And so we know that we take physical health, we send you to a doctor, you get an exam to make sure that you're okay. So can anyone comment on how we can roll in not only funding of mental health, but in incorporating it into the routine of pregnancy, post-pregnancy, and after birth for mothers?
This is from New Jersey. I'll take a stab at that. I mean, you talked initially about the doulas, and I think that before you get back to the doctor after 6 weeks, you can be seen by your doula. And so one of the things that we're looking to do in New Jersey is really work on developing that workforce. but give them some basic training in sort of mental health screening, because we think that they can sort of get in there before women get back to a doctor's appointment. And so we're spending quite a bit of time with gracious funds from Title V. We are putting out a doula learning collaborative, which is the first of its kind, but a real workforce development center that will help them with training and things of this nature, because we see them as being part of the solution and as really being able to sort of stand in the gap before you get to the 6 or 8 week postpartum checkup. Somebody else should be checking in on you. And that may be a person that you feel more comfortable in sharing with in terms of how you're really feeling, because it's somebody that should have been with you through the course of your pregnancy and birth and postpartum.
Congresswoman, if I could just add to that as well. One of the reasons, again, that we're advocating for extending Medicaid 1 year postpartum is for that very reason, that we have to provide more care after the baby comes to make sure that mothers are getting the kind of care that they need to deal with not only their physical challenges that they may be facing, but also their mental health challenges. Nearly 1/3 of all the maternal deaths that happen in this country happen 1 week after the baby is born out to 1 year. And one of the leading reasons for that is tied to mental health challenges. So this is really a critical issue. We would love to expand these access to care models like postpartum group care, which we think can be as effective as what we find in group prenatal care. We know that there are doulas who provide postpartum care as well. So not just doulas that are there, at the time of pregnancy and delivery, but can we have postpartum doulas who can stay with the mom even 1 year out? And then the last thing I would just say is that it's really important that we make sure that this fourth trimester is really embraced as in this whole model and continuum of care. We cannot just look at addressing the maternal and infant health crisis as if it's an issue of pregnancy and childbirth. It extends beyond. And I think once we start to really embrace that notion, we can sort of look at the continuum of care and make sure women are provided the kind of access to care that they need that covers them, especially 1 year after the baby is born and beyond.
Thank you, Madam Chair, and I'll yield back.
Thank you. Thank you. I think Congresswoman Watson-Coleman. No. Is there any members that I have missed for a second question here?
I would like to ask the second question.
All right, you go ahead, and then we'll wrap. Okay.
Thank you so much. My second question is the certification of doulas. How structured? I've always wanted to ask this question. How structured is that training, and what the certification that is uniformed or universal? Can someone talk to me about the certification and the recognition of you being qualified to serve as a doula?
I'm happy to take that on. In New Jersey, we have a doula Medicaid reimbursement benefit that went live January 1. And so as you know, Medicaid doesn't just pay for anything. And so they're really looking to do just what you asked about. What is the certification? What are those core competencies? What are those standards? So we at Department of Health have worked very closely with the Department of, with Medicaid to really establish what those core competencies are. And so there is a sort of a standard competencies around birth and support, but we've also added health equity and adverse childhood experiences to the training, because we think it's a requirement for doing community-based work in New Jersey.
Well, this is where I get stuck. I understand that we have doulas, but is there a national standard? Like to be a nurse, there's a national standard. There are benchmarks that you prove competency in, and then you issued a certificate. Is there a national standard?
I think national sort of custodian of that is sort of DONA, which is a national doula organization. So they do provide certifications, and different doula training organizations provide certifications. So I would say yes. They're varied and they're diverse.
Is that an issue being varied and diverse, or where are we with that?
I think it can be. And in New Jersey, what we're doing is really working initially with Medicaid to establish what that core competency is. And then, as I mentioned, because of the challenges, we are actually establishing a doula learning collaborative. So an entity that would be responsible for that workforce development. So if you say you are a community doula in New Jersey, this is what that means. And so we've also received support from the state to invest in a doula registry that will really allow us to sort of maintain that database, and just in response to your questions, really maintain some standardization and some certification.
Thank you, Madam Chair.
Madam Chair?
Yes, go ahead, Congresswoman Roybal Allard.
Yes, Congresswoman Butler, this is a very important issue for her, and she wanted to be here, but unfortunately, she's been detained. So she just texted me a question that she would like me to ask on her behalf.
Go ahead.
Breastfeeding is a high-value, low-cost public health intervention that provides a substantial return on investment. Since funding was first directed to support breastfeeding programs in 2012, breastfeeding initiation has increased, with exclusive breastfeeding at 6 months, increasing from 16% to over 25%. Funding for CDC breastfeeding programs support data collection, track breastfeeding rates, and support partnerships with states to help employers support breastfeeding mothers with places to pump and store breast milk, and much more. Data from the CDC shows that most infants start out breastfeeding. However, these numbers drop precipitously in the weeks and months after birth. Dr. Gordon, can you speak about how our nation's breastfeeding rates impact maternal and infant health outcomes?
Thank you for that question. Breastfeeding is one of the primary interventions for reducing infant mortality. And what we know is that it's hard. For a lot of people, it can be hard. And so there's in the postpartum period, many families don't have the intensive support that they might need in order to successfully breastfeed for a long duration of time, at least exclusively for the first 6 months. The newborn, after birth, the newborn gets lots of visits through the pediatric providers, but the person who gave birth usually only gets sort of the 6-week visit after hospital discharge, and 40% of people don't even bother by that point. So there are a lot of issues that can occur in the postpartum period, many of which involve challenges with breastfeeding. And postpartum care is an area where again, many other high-income countries are doing it much better than we are. In England, for example, people receive home visits from multiple types of providers in the first several weeks after birth. Community midwives in the US are doing this too. But especially during this pandemic, most people have had little to no support after they've given birth. And in a country that spends more on healthcare than anywhere else in the world, our families deserve better care than this. I would encourage funding for demonstration models that incorporate physicians and community health workers, midwives, lactation consultants, doulas, and public health nurses, and build in home visits in those first couple of weeks, as well as including a postpartum depression check-in around 12 weeks when many people have to return to work and breastfeeding relationship changes, and then have regular telehealth check-ins throughout that whole first year.
Okay, thank you.
Thank you. Thank you very, very much. I'm going to ask just a couple of questions, and then I'll just wrap up for a close. Did I miss any members? Okay, I think we tried to, but and this is a quick yes or no answer. Should pregnant women and lactating women be part of clinical trials? I see Dr. Gordon saying yes. Is it?
Yes.
Repeat
Yes.
that okay. Yes.
Yes.
Okay.
Yes.
Thank you. Thank you. Then, are there any any restrictions in states on doulas and midwives? Are there states that don't recognize these areas of study, or and so that we can't go further with branching out into these areas of shortage of workforce? Do we have states who say no, you can't do that?
Yes, we do.
Okay.
We do. Certified nurse midwives are able to get licensed in all 50 states and jurisdictions. Certified professional midwives who attend home and birth center births are able to be licensed in only 34 states and the District of Columbia. And certified midwives are, I believe, licensed in 6 states right now.
Okay.
So
that's a state issue.
Yes.
So it becomes a state issue. So it's something that we can look in. Let me ask another quick question, which has to do with research gaps. And Dr. Sakala, what are some of the key gaps in research on maternal health? What are the questions that we should be trying to answer? And I guess you also spoke about disaggregating the data. What kind of improvements can we be making in that area? Just overall question with regard to research, the gaps, and what should we be trying to look for?
Yes, so thank you for that question. As I included in my testimony, I would reiterate the importance of measuring the impact of the community-based perinatal health worker groups that are arising organically across the country to fill gaps in trusted, respectful, culturally congruent, accessible care. That to me seems like a very promising practice where we really don't have the evidence to give them the full support that they may deserve. And I think I appreciate all the mental health questions, and the same thing. We have a shortage of mental health providers in this country, and we are still struggling to integrate mental health services within healthcare. And there was a PCORI, that's the Patient-Centered Outcomes Research Institute, study that found that home visitors can be trained to make a difference in people's maternal health. I think we should be looking at what these extended model doulas can do, what other types of providers that are providing support in these community-based groups can do to impact mental health. I think that letting communities lead and letting them understanding that they have the power, the relationships, the connections, the understanding that is often not there with other kinds of health professionals. And so we should be looking at how we can affirm those contributions.
And I would I think there's some areas that we need to take a look at in terms of where are the areas that we know less about in terms of research on maternal health?
Chair Delaro, if I could answer that question, I think there. So at the March Times, I think many of you all know we invest a significant amount of money into the research around maternal and infant health. There are a lot of areas where we have gaps in information. One of the biggest areas is around how social determinants of health really impact maternal and infant health. We have some evidence around that. We know that about 80% of our overall health is really determined by what happens in our day-to-day lives, the condition of our housing, safety of our community, access to good and safe nutrition, and those kinds of things. We don't still yet have enough information on exactly how those social determinants really impact maternal health. The other thing I would say is to go back to this issue of maternal mental health. We know that stress, anxiety, addiction, trauma, all of those things have a significant impact on our health. How those things impact the health of women who are pregnant, postpartum women, moms, we need to understand that better as well. The last area is around comorbidities. We again have some evidence to show how hypertension, how diabetes, how obesity, how other nutrition-related conditions impact the health of women, the health of moms. We need to have more and more information about that, especially around cardiovascular conditions, because we know that is a leading cause of health outcomes as well. We know that 2/3 of American adults have one of these chronic conditions. So how those kinds of conditions actually then impact the health of moms through pregnancy and beyond, we need to do more research and invest more money in those areas as well. Last area I would just say is we spend a lot of time talking about these health inequities. We have to go deeper in understanding how health inequity, how maternal health equity issues really impact communities of color in particular, and investing more time and attention in that as well would be important. Thank you.
Just a quick follow-up to that, which is with the gathering the information that you've talked about, the social determinants of health and housing, all of those, the stress, anxiety, trauma, the comorbidities. Is there, do we need research into these areas? Do we need to commission some sort of a study to look at these specific areas? Do we have a data that is just not collected at the moment? How do we are able to get how does a lack of housing, how do evictions, how do these social determinants, how do we gather that in one place to make the impact on where we need to go?
Well, I'll start with that. I think there's two issues. One is a research issue. Are we looking deeply at these issues and really understanding not only the causes of some of these outcomes that we're seeing, but also what are some of the solutions? But we also have a big data problem, and that came up earlier.
Yes.
We have to invest more money in data collection, data surveillance. The maternal mortality review committees, for example, the most important thing that came out of the Preventing Maternal Deaths Act was the fact that we can now have in every state, and we do have them now in every state, but 3 states, they're underway, maternal mortality review committees that allow us to finally collect the data of really the underlying causes of maternal death, so that we can not only know exactly what were the causes of these maternal deaths, but what are the solutions. Hopefully the collection of better data, the reporting of better data will actually inform better research so that we can look to better outcomes. That data surveillance that CDC does, that the states do with the maternal mortality review committees, all of that data is really important. And we have underinvested in data collection efforts, as well as the research that we need to develop solutions as well.
Okay, thank you. One of the, I'm just going to say, as I would get back to the organizations, I think it would be useful for us. I saw the maps in some of the background material that we had, and to be very honest, that was very, very confusing. What I would love to see, and I don't know if your organizations can do this for all of us, is where are the counties or where are the states in which these counties exist? Where are the deaths? The analysis of where in the country we are finding these circumstances, to see where we need to target, if you will, where we're going and what we are doing. So if you all have, any of you have the capability or the capacity to do that, or you would need assistance in doing that, please let us know, because I think that can be enormously helpful as we are trying to look to, in many regards, is have our, and where there are no OB services as well, to take a look at this, is how this lays out across the country, and look at the ways in which we might be able to attack it in that way, and persuade potentially some of our colleagues, that these are investments that are essential, not just worthwhile. They are essential if we are going to try to address this problem. So we can talk, we can be in touch with all of you on that. Let me just wrap up, and you've been really wonderful. And I think we all are so indebted to you for the work that you are doing and the clarity which you have brought to this issue. And I'll go back to saying what I said at the outset. You not only are crystal clear on what the problems are, you are crystal clear on what the solutions that we can address. Oftentimes, you can't really get your hands around a problem because it is just so overwhelming. This needs a lot of work, but we have some identified courses that we can move through. So and one of the things that came out, and I will just say this to you, and I see my colleagues with Congresswoman Lawrence, Congresswoman Roybal Allard. We looked at CDC, the Perinatal Quality Collaboratives, Maternal Mortality Review Committees, Surveillance of Emerging Threats to Mothers and Babies Network, Newborn Screening, the Workforce Training, Midwifery Training, doulas, data disaggregation, NICHD and their research, CMS, what they're going. I don't know, we could talk at another point about this HHS partnership that you have with the March of Dimes and so forth, and what that's all about. Paid family and medical leave, maternal health hotline, the Momnibus legislation, and as the list goes on, we've had substantial recommendations from all of you. And this winds up being that we've got a ton of data. Yes, there is more that we need that has been laid out, but for God's sakes, this crisis can be addressed, and we shouldn't be crying out in the wind. Because I believe it's a national disgrace, to support women, to support mothers, to support their children has to be a fundamental value of this country. And I hope we can look to you again, because I know, and I'm looking only to the 2 members, but I can tell you about all of our members, we are going to address this issue because this is a subcommittee that can do it. So we're going to be seeking your guidance. I'm always mindful of what my colleague, Congressman Cole, says, that it is about the allocation and the resources, but by God, where are our priorities? And let's move ahead on this. So thank you all very, very much for this morning's testimony and for the work that you do every day. Thank you. And I'm banging on the table. This hearing has come to a conclusion. Thank you. We're adjourned. Bye-bye. Thanks.